So we have to catch up, and we have now debate, I believe. And debate should be about AF ablation and left appendage closure in a single procedure or sequentially. So we have proponent, and that's Claudio Tondo from Milan, proponent of the approach to do it together in a single procedure.
Good afternoon. Thank you, Joseph, for this kind of invitation. Unfortunately, I don't have Julie Gupta, my longtime friend, just to have a very good debate. Before I go to really serious stuff, I'd like just to tell you that probably I don't know how many arguments Jirai could have to counteract my position, because actually, as you know, as a great supporter and key opinion leader for AF ablation, but you know that he is very active in the Twitter or other platform, and I was able just to catch some of the statement that he has done, like that it's much better to have a appendage closure in combination with ablation to prevent subclinical stroke and prevent dementia in AF patients. And then he was a part of a group of friends. You can see just in the right end of the slide that he was considering the combination of the two procedures, quite a revolution and obviously an evolution. And last but not least, also he has become a great supporter of the option trial that is the first clinical randomized clinical trial offering actually the option to have a combination of the two procedures to reduce the recurrence rate of arrhythmia after ablation plus the closure of the appendage. But let's move on. And I do really think that we have a good wealth of data in the literature coming from a single center, multi-center study, registry, which actually, emphasize that it's feasible and quite safe to combine the two procedures in a one-time procedure. Obviously, we have data considering that at the very beginning was radiofrequency or cryoballoon ablation used to combine with the appendage closure. And one of the most striking data is the fact that you can greatly reduce the bleeding rate and the stroke rate in those population who underwent a combination. But why concomitant? Probably we need to also appreciate the fact that patients are much more willing to have just one-time procedure than a two procedure, just apart. And also we have the observational studies, meta-analysis in the last few years, which highlights that it's possible to have a very safe procedure, and there's no higher risk as compared to the left atrial appendage alone. This is one of the latest meta-analysis which consider a quite high number, more than 50,000 patients underwent a combination of the two procedures. And in this meta-analysis, combined appendage closure and catheter ablation was similar in terms of efficacy and safety to the isolated appendage closure. You can easily appreciate at the right end of the slide that this, the behavior is in favor of the combination. And again, we have the option trial which was published last year. And they, randomized patient to two arms. I don't want you to spend much time, but, the conclusion was that you have the primary efficacy endpoint, that the combination showed that superior safety and non-inferior efficacy compared to the oral anticoagulation. And probably due to the number of patients included, we were unable just to offer, a higher efficacy of the combination of the two, regardless the mode of clinical presentation in terms of paroxysmal persistence. You can see that ablation plus the occlusion of the appendage behaves much better than ablation plus oral anticoagulation. So now we are in the era of a PFA, and probably we need just to take the advantage of using PFA in combination with the appendage closure. The hypothesis is probably the one-shot PVI that is allowed from PFA. And obviously, as you have the chance to see in these 2 days, the chance to have a good isolation of the left posterior wall, especially in a patient with a persistent atrial fibrillation. This could be really an advantage, especially if we consider that persistent AF patients are much more prone to have recurrences over time, and therefore offering the occlusion of appendage could be a benefit, an asset in our portfolio. Obviously, the PFA has the potential to induce fewer complications, and this is something that we need to take into account when we offer the combination to our patients. And the PFA is independent to the vein occlusion, unlike a cryo, for example. And then also the single transeptal puncture is more suitable position for the appendage closure. And there are much discussion, a lot concerning the edema, the commodine ridge between the left superior and the left superior pulmonary vein and the appendage, that it might be less produced by the PFA as compared to RF or cryo, but this is still has to be demonstrated. And as already mentioned before, we are much allowed to have an extensive ablation with the PFA. And this is just one of the latest study, the single center study, which demonstrated the feasibility and the safety of doing a combined PFA plus appendage closure in this cohort of patients, just patients with the PVI were included. This is to be published. It's one of our investigational studies, and which we want to investigate the role of a PFA in a patient, older patient that obviously are much more flare and probably much more prone to have a contraindication or maybe having bleeding risk as opposed to younger patients. So we have another reason just to offer PFA to patients who could be considered a good candidate for appendage closure as well. This is an old slide which comes from the consensus document that we have written in 2014. And I don't need just to go through, but again, I think that we need to consider that across, the entire spectrum, I think the patient needs just to be inquire whether or not they want to continue with the anticoagulation, or maybe they are unwilling to be on anticoagulation, or just because they already have a bleeding risk, and therefore this is a good reason. The There is a wonderful paper from John Camps, and I just put this slide just because I want to stress the concept that, and I'm probably, my friend Gupta will, come up with the same concept that if we look at the guidelines, I mean, just usually when they, are published, are, far behind concerning the technological evolution or what the electrophysiologists or interventional cardiologists want just to push. And if you look at the upper, portion of the, the figure, the diagram, you have obviously they need to have a meta-analysis, clinical trials to convince people, the writers of the guideline that sometimes are not really experts in the matter, just to give a good level evidence, and therefore, so if you look at the appendage closure, there is a weak recommendation. If you look at behind that diagram, you have electrophysiology, interventional cardiologists who are pushing for having a much stronger recommendation, and this is a very conflicting area in which probably we need just to consider how and when we can change the recommendation concerning the appendage closure and the catheter ablation of atrial fibrillation. And again, this already we have mentioned the role of PFA. I mentioned the persistent EF patients because they probably are much more prone to develop recurrences over the follow-up. And this is one of the first publications from our group showing the feasibility to completely and effectively isolate the posterior wall and then to close the appendage. And this is one of the latest multi-center comparative study where in this study the authors have shown that there's not much difference concerning the peri-device leak. If you consider the 3 millimeter, if you go up, there are hints that you might have or more leaks in the combined procedure as respect to the appendage closure alone. And again, there's a concept of electrical isolation of the appendage closure. This is one of the modalities to reduce the recurrences, especially in patients with persistent or long-lasting persistent AF patient. Here we have another example. But if you do that, if you regardless the modality, how you want to achieve the electrical isolation of the posterior of the appendage, you might have the occlusion at the same time, just to reduce, obviously, not only the recurrences that has been shown to be a part of the electrical isolation of the appendage, but also the bleeding risk and the stroke risk. And here, there is a editorial from one of my group and Luigi Di Biase that probably the use of PFA, it might be less thrombogenic, plus the appendage closure and the combined procedure may probably overcome this problem. And here we are going to publish the comparison between PFA plus appendage closure to the historic of using radiofrequency catheter ablation in our series with appendage closure. In terms of efficacy, we can say that compared to RF, PFA much characterized by a less procedural time and less procedural complication as compared to radiofrequency, even though there's not much difference concerning the clinical outcome, but probably there's a due to the limited number of patients included. So, dear friends, I think that especially considering the PFA plus the appendage closure versus radiofrequency or versus cryoballoon closure, the comparative studies so far is lacking, limiting the direct assessment of the relative efficacy and safety, but probably if you use a PFA, you might have a strong reason to propose just a single time of the two procedure, and there is a trend of lower arrhythmic recurrences if you use a PFA, and probably you might have a much more extensive ablation just because you can go safely to the posterior wall as well. But there is one point, I'm pretty sure that Gupta will make a point, that is money. And unfortunately, I think that we need just to push the policymakers in considering the reimbursement, especially in Europe, and not in the US, where the combination is skyrocketing just because they have a good reimbursement as opposed to Europe. And finally, I'm really sorry that Gupta is not here because, he came from Liverpool, right? And Liverpool, lost to PSG. I mean, I think probably Sergio is much more, happy. And that Inter Milan is in the final match on, May 31 for the Champions League. Thank you for your attention.
So Jirai had...
we have a presentation.
Jirai had some serious family reason not to come, so he sent his presentation in a Zoom format. So we will listen to this presentation, then we will make a 15-minute break. There is still coffee and some refreshments, and then we finish with a last round of lectures. We limit discussion so that you can catch buses around 7:30 to this meeting, social meeting in the evening. So that's a plan. So can we run this recording from Dr. Gupta? Okay.
This is Dilas Gupta from Liverpool. It's a great pleasure to debate my dear friend Claudio Tondo about this very important topic, in which I'm going to try and convince you that I do not think that adding left atrial appendage closure to atrial fibrillation ablation routinely in a single procedure is a good idea. Many thanks to Professor Holzner and the organizers for inviting me to do so. I would love to be with you in person, but sadly, this time round, I'll have to make do with presenting this remotely. I'm going to try and convince you by just giving you 3 arguments. Number 1, I strongly believe, I'm sure many of you believe in this room as well, that AF-related stroke risk reduces with catheterization. And if you were to start adding in left atrial appendage occlusion to all patients undergoing catheter ablation, admittedly those with a high CHAS-VAS score of 2 or more, we will be grossly over-treating this population. Number 2, there's a safety risk. If you start combining left atrial appendage occlusion routinely to AF ablation, there is a potential for malsizing because of the ablation edema. I'm going to show you some data from our own laboratory. But also, I have strong concerns that when this kind of procedure goes out to lower volume operators and institutions, we're going to see far more complications than is the case so far. Last but not the least, it's a more philosophical point, but it's relevant to all of us, that just because we can do it doesn't mean we should do it. The health system has finite resources, especially in Britain, as stated in many of your countries. And if you're going to start chucking in left atrial appendage occlusion devices to everybody who undergoes AF ablation, we have to really ask the question that can our health system really can afford it? Let's start by talking about the first, perhaps the most important tenet, that AF-related stroke risk reduces with catheter ablation. The Current scientific guidelines are very clear that the decision regarding anticoagulation after ablation is based solely on Charles score and not at all on whether or not the AF ablation has worked, which I think is a very flawed position. And hopefully these guidelines will evolve over the next few years as more trial data come through. In any case, these guidelines were based on data derived from a completely different population than the population that we treat with the ablation. They were largely primary care populations, elderly populations, asymptomatic atrial fibrillation, which is completely different from the kind of patients who are treated in the lab. Furthermore, they don't take air burden into account, which is a very, very strong limitation of any of these clinical risk scoring systems. They assume that the oral anticoagulation is low risk, which is not, because long-term data over 20, 30, 40 years are just not available. Also, they assume that an oral anticoagulation is going to be given in a conventional daily manner, whereas they don't take into account the fact that there are now lots of variables which allow us to detect and monitor atrial fibrillation burden, thereby paving the way for pill in the pocket no treatment. And as I said, they assume that Charles score is everything, is the holy grail, but clearly that's not the case. Lots of concerns about these scores are that they were developed many, many years ago at a certain different population than the ones that we treat. And even in those populations, the Charles scoring is not very predictive with a C index of just 0.56 to 0.58. So hardly better than flipping a coin as to whether the given patient in front of you is actually have a stroke or not. It's definitely not been validated in a post-AF ablation population. So a number of EPs believe that in the chance score is crude, oversimplistic. It really encourages overprescription of oral anticoagulation. We know that chance score just takes into account simple clinical factors, which are only one aspect of the decision making, one aspect that is determining stroke risk. It doesn't take into account electrical factors like air burden or genetic factors or biomarkers, which we know are also important in predicting stroke risk. A number of studies, largely it's a population-based cohort study that's shown that patients who have undergone catheter ablation or atrial fibrillation are a lower risk of stroke as compared to a matched population who has not undergone AF ablation. And even the randomized trials such as Cabana and Crossin have shown that the active groups had a much lower risk of stroke over follow-up as compared to the control groups who did not undergo catheter. The values did not reach statistical significance, but they were quite different from each other, as you can see. And had the studies continued for a bit longer, that difference in stroke risk would have certainly reached statistical significance as well. And because a number of us EPs believe very strongly in this, we don't follow the scientific guidelines as closely as we should, perhaps. As you can see from many studies, that patients are 12 months out from the AF ablation, their oral anticoagulation has absolutely no bearing to the CHAS score. Many patients with high stroke risk, high CHAS score, not taking oral anticoagulation a year out from the ablation. And indeed, it looks like that we're probably not doing these patients any disservice by stopping the oral anticoagulation, because a couple of very large meta-analyses have shown that these patients in whom oral anticoagulation will be stopped, they really have no higher stroke risk whilst having significantly lower bleeding risk. In fact, there was one meta-analysis that suggested that even the stroke risk may be lower in this group of patients, probably because this is a cohort of patients that has been selected by their physicians and deemed to be at low risk of stroke, and hence the oral anticoagulation has been discontinued. AF burden is increasingly recognized as an independent risk factor, which means that rather than us adding just a standard threshold for the CHAS score upon which to base our decision on oral anticoagulation, we really should have a much more nuanced approach in which we look at stroke risk as a continuum across the AF burden and across the CHAS score. And we should take both of these things into account when deciding what a patient's risk of stroke is. you obviously know that catheter ablation reduces the risk of AF progression. This was proven in the test trial using radio frequency, or even the early AF trial using cryoballoon. And we also know that once the patient undergo catheter ablation, there's a marked reduction in the AF burden, which is important because increasingly in studies which have used implantable devices, there's emerging evidence that there is a strong temporal association between atrial fibrillation and stroke risk. Initial studies have suggested that this is not the case, and that AF is some kind of an epiphenomenon which happened to coexist with some atrial myopathy. But the fact of the matter is that there is a strong association between occurrence of stroke and atrial fibrillation in the preceding 4 weeks. This is important because it then opens the door for pill in the pocket type treatment. I know that the impact study, which studied pill in the pocket or anticoagulation, was negative, but what we don't realize is that almost all the patients in that study underwent the oral anticoagulation with vitamin K antagonists. And obviously, we know that vitamin K antagonists have a very long onset of action. With current NOAC therapy, pill in the pocket treatment is being studied in the REACT AF trial, and the results will be out in a few years' time. And obviously, wearables have improved AF detection capabilities hugely as well. Second thing is the safety of doing joint procedures, particularly the effect of edema in causing a malsizing of the left atrial appendage landing zone. We know that that is the most important determinant of the peri-device leak. And we know that in the option trial, in which patients were randomized to either having a Watchman Flexter device or an anticoagulation, there were two cohorts of patients, those who underwent the two procedures sequentially, which was about 60% of the population, and others in whom the two procedures were done in the same sitting. Now, obviously, these were not randomized, but the fact of the matter is they showed that both devices of both approaches are feasible, and that there is no difference in the primary outcome, whether or not the two procedures were done sequentially or concomitantly. However, there's clear geographical differences in practice between sequential and concomitant procedures, and these were largely driven by reimbursement reasons. But more importantly, there were big differences in the baseline characteristics. So the patients in whom the left atrial appendage occlusion was performed in a sequential manner were actually at higher risk as compared to those in whom the two were done concomitantly. They had a higher chance of score, they had a greater prevalence of congestive heart failure, and also major GI bleeding. Pacemakers are also more prevalent in this population. And although numbers are small, the fact remains that there was only one patient on follow-up who had a large peri-device leak of more than 5 millimeters. And this was actually a patient who had his device concomitantly. Similarly, there was one patient who had a peri-device leak subsequently complicated with a stroke. And again, that patient was in the cohort of patients whom the appendage occlusion is done concomitantly. Last but not the least, as we know, that in the option trial, all patients underwent either radio frequency or cryoballoon ablation. No patient underwent pulsed field ablation, which clearly pulsed field ablation is the one which is going to take off in a big way in terms of concomitant procedures, but obviously it makes the procedure so much quicker. We know that pulsed field ablation does lead to large lesions, lots of rise of troponin, hepatic enzymes. But does that impact upon edema or affecting the left atrial appendage ridge, and how that impacts upon sizing? So this is an ongoing study that Nandos Vegeli from Budapest has led, along with our center in Liverpool, and also Center in Warsaw in Poland. And we studied 91 patients who were undergoing pulsed field ablation, and we studied their left atrial appendage landing zone and the LA ridge thickness pre and post pulsed field ablation using transesophageal echo or intracardiac echo. And what we found was that there was a clear difference pre and post ablation in terms of thickness of the left atrial appendage ridge, which measured out also in terms of the landing zone. Last but not the least, as I said, and these are expensive procedures. They're often not needed, and the majority of patients can you really afford them? But that's a question which I think is best discussed with. So to summarize, concomitant left atrial appendage occlusion plus AF ablation is a niche product, and it should not be offered to everybody. It should be used sparingly in those patients who truly have contraindications to oral anticoagulation. Just because we can, it does not mean that we should. I'd like to end on that note, and once again, thank you to the organizers for this opportunity, and I hope you all are having a great Congress.
So as I mentioned, we will make now 15-minute break, and then we finish the last block of talks.